So I put some pictures of you. Who's down here? So when you hear the lecture from other people, you have to think about the speaker's bias. That is really important. So I will talk about the bias once again, but yeah, I have a bias. I'm a microsurgeon, and when I see this kind of wound, I always think about doing flaps for the cases. But there are many methods we can heal the wound. We can do the skin graft, negative pressure wound therapy, local flaps, free flaps. So this is the usual ladder we learned. This is a stepwise decision-making process. We choose the easiest one first, and if it's not possible to heal with the easier method, we go to the next step. It's a stepwise decision-making process. And another thing we learned is a reconstructive ladder concept. So we can choose the best option for that defect. That's a reconstructive ladder concept. But not every surgeon can do every surgeries, right? So people have different tools. So what if the patient does not know how to do the free flap? Or what if they don't know how to do tissue expander, or it's not possible? So sometimes if you don't know about certain things, it's really difficult to choose the best option for each defects. And so I like to talk about the reconstruction toolbox concept for doing the reconstruction surgeries, because every microsurgeons and plastic surgeon who do the reconstruction, they will gonna choose the method they can possibly do, right? If they cannot do the surgery, or if they don't know how to do the surgery, they will not use that method. So that's the reason I want to empathize on the toolbox concept. And when you once become a microsurgeon or the reconstructive surgeon, you will have small toolbox, and there are only the LD flap maybe possibly in your toolbox, or sometimes the skin graft will be your best tool for the reconstruction, like that. So the thing I always empathize is that we have to evolve your toolbox during your practice. So when I think about my toolbox, maybe the toolbox before 10 years was totally different from the toolbox now I have. So what if this patient comes to your the outpatient clinic and asks for the solution? This is 6-year-old female, and initially she went to the other plastic surgeon in Jeju Island, and he didn't actually perform free flap surgery. And initially when he saw this patient, he thought the free flap was the only solution for the patient, because there was Achilles tendon exposure and the calcaneal bone was also exposed. So he sent to me the patient for the free flap. But when I saw this patient, I have a different toolbox. His toolbox, the microsurgeon in the plastic surgeon in the Jeju Island didn't have a microsurgery tool. But I have all the tools, and I also have a really good tool I used to use. That's a wound management. Is the best tool actually I use for most of the wound patients. And I think because the patient is young and the wound is small, I think it can be healed by the secondary healing. And I told the patient to wash the wound with soap, and I let him come after 2 months because she was living away from the soul. So this is 2 months after surgery, and actually the wound was healed around 6 weeks. And as you can see, the condition of the wound was really nice. So so not the only one surgery is the only answer for that wound. Actually, you can use so many options, and if you have a wound management tool in your toolbox, it can be a really good tool that you can use for most of the defects. So this patient, 28-year-old female, had a low extremity trauma, and in other hospital, the orthopedic surgeon did some skin graft and did 2 flaps for the patient. So this was after the surgery. The patient had a trauma on the right leg, and skin graft was done on the lower leg, and I think there was a deep wound on the knee and the ankle. So for the knee defect, they did some rotation flap on the knee, and for the ankle, because the patient, we need a thin flap for the ankle, they elevate large medial rotated perforator flap the left side. So fortunately, we saved the limb, but she was crying in my outpatient clinic because of the scar. And so we have to, in this patient, we did some fat graft and debulking of the flaps, like that. So for this patient, maybe she was not happy with the result. And that orthopedic surgeon's toolbox, maybe he has every tool in his toolbox, but still there's a space for the evolution of his skills, and you can maybe think about more cosmetic aspect of the reconstruction, and maybe he also can improve by time and effort to have a better toolbox for the reconstruction. So there are many ways we can choose flaps, and many flaps have pros and cons, and there are reasons why we choose certain flaps over other flaps. So when you choose certain flaps, you have to think about the defects, and you have to think about the flap. First, we have to think about the distance from the vessel to the defect. You have to think about the width and dead space of the defect. And during the surgery, we don't want to change the position of the patient, because if increase the operation time and also the chance of inflammation, so infection, so we don't want to change the position. And also the donor scar is really important. So based on that, we had this kind of algorithm. So based on the position of the patient during the surgery, we can choose based on the width and whether we want to use the muscle or not. So there are many flaps we can use, and based on that algorithm, we choose flaps for defect. This is a medial upper calf defect, so we elevated thin ALT for the defect, and you cannot see the pedicle because we didn't go to the main descending branch. So this is after surgery, the contour, and the shape after the radiation therapy is really good and had no necrosis. And for the larger defect, because we thought the wound cannot be closed primarily after we elevate the skip flap, so we did the ALT for the defect. The flap is really large, and for this kind of a defect, for the capsule reconstruction, we can use ALT with the fascia, and we can use the fascia to reconstruct the capsule and skin to cover the defect. So we elevate ALT with the fascia and cover the defect. And after radiation therapy, the patient has a full range of motion. So ALT was our workhorse flap for a very long time, and 69 tumor, really large. This is the biggest flap I ever elevated. So this is ALT 35 by 22 centimeter ALT. Without any marginal necrosis, we can elevate it. This patient, we used 2 perforators, one from the descending branch and one from the medial branch. So the medial branch one, we anastomosed the IMA, and lateral branch, we anastomosed the rhodopsinus. So 2 artery was anastomosed. And I showed this picture several times. This is Kaposi sarcoma patient, and this is a defect. So the thickness of the thigh was slightly thick compared to the defect here. So we elevate within the superficial fat layer. So we can elevate really thin flap. And unfortunately, this patient had 2 separate perforator was going to the different source vessels, so we did the turbocharged. And this is after surgery without any deburking surgery. So ALT was our workhorse flap. We use it for every cases. Sometimes when there's a muscle is needed, we use muscle. And the basolateral, this muscle was also harvested with the skin flap. And we use it for very many cases. Also, we use it for the diabetic foot reconstruction. In diabetic foot reconstruction, the most important thing is controlling the inflammation. So the first week we did multiple debridements and make the wound clean. So this is a chronic infected wound. This is the acute wound. So we change it to the acute and we cover with the free flap. In many cases, or just like this trauma case patients with a large dead space, we just elevate with the fascia and the muscle to fill the dead space and cover the defect. ALT, it's really good flap. It has a long pedicle, but the scar is not that good. If the skin graft is needed, it's really ugly, and some of the times it's even thick above the superficial fascia. And we can use the medial shura perforator flap, but scar in Asian is really bad. So in Asians, we love to wear shorts. So if the scar is visible, the patient does not like that scar. So in the prone position patient, we used to elevate the flaps from the back. So we elevate several escape flaps from the bottom, and without changing position, we can do the microanastomosis, flap excision, and wound closure, everything. Escape is also really nice flap to elevate, and the problem is that we have to change position if you want to do the initial surgery in spine position. We also, this is a 26 clear cell sarcoma patient, the knee. After excision, the defect was quite wide. So we found some of the perforators here and we did the propeller flap. And without any marginal necrosis, you can elevate large flaps. And after radiation therapy, during the radiation therapy, there was no problem with these patients. And we use a lot of propeller flaps on the cancer patient, the thigh and the trunk. So I want to talk about designing propeller flap after this lecture. And this is the largest the flap I elevated. So after excision of the modulins also, the defect was quite large. And after the orthopedic surgeon did the excision, we did additional excision because there was unstable scar was remaining here. So after the defect, after the excision, we excised like this. So initial plan for this patient was that we wanted to do the DIP flap, DF flap because the defect was too large. But for the DF flap, we have to change the position multiple times. So we tried to find the flap from the back. And fortunately, we found really nice perforator here, and the axis of this perforator was going laterally, so we elevate really huge propeller flap, and it was after surgery. I'm going to talk about this case later. So propeller flap is really nice flap because we use the surrounding skin, so the control and the thickness is quite same. Some of the cases, if you need bone flaps or some periosteal support, we use either femur condyle flap to cover the defect. So this patient had a non-union on the femur, and we cover the fracture site with the MFC flap, and the bone was healed. She was suffering from more than 10 years because of this non-union, but it was healed after the surgery. And our workhorse flap is skip flap. Initially, the Professor Hong visited some conference, and Oshima was talking about the skip flap, and we followed his steps, and we use it for the small defect like this. Because the cons of the skip flap is that it has a short pedicle, really short pedicle, and we thought initially we could only close the donor side when the width was 8 centimeters. So we use it for the small defects like this. And the scar, the donor side scar was really good. So we were really into this flap. And we applied that flap when the recipient vessel was located within the defect. Because in this case, we don't need a long pedicle. So for that, we did multiple flaps. This contour is amazing, and the donor scar was also good. So we use it for the toe reconstruction like this. Without any debulking surgery, the contour was really good. Also, this is diabetic foot patient, bilateral case. We did flat coverage on the post after the minimal amputation. So for this case, there are many ways you can control this necrosis. We can cut the first ray here and close primarily, but our principle is to preserve the proximal phalanx of the first ray because that segment is really important. The plantar teres fascia is attached to that segment, and also the flexor brevis muscle is also attached there. So if you preserve that, we can preserve the pressure pattern of the foot. If you do the first ray amputation, it becomes like a square. So you want to preserve the arch of the foot. So that's the reason we do the flap and preserve the proximal phalanx. And this kind of patients, we need a capsule reconstruction. We used to use ALT flap to reconstruct the capsule, but as the skills improving, we elevate the fascia with the skip flap to reconstruct the capsule and cover the defect with skin. And this is the first case of long pedicle. We need only 5 centimeters from the defect. The pedicle was here. It was the perforator from the ATA. But initially, for those kind of patients, we use ALT for the reconstruction. But this case, this was the first case. We elevate extra 5 centimeters from the margin of the flap, and the anastomosis is the perforator. So this is a marking. It's not a partial necrosis. So the flap was successfully done without any problem. And we do some of the acute trauma patients and do new skip. 23 by 8.5 centimeter large flap to cover the defect. And unfortunately, the skin on the ankle was not so good, so we did second skip flap here. And here we did third ALT because the patient was not satisfied with the depression when the patient wearing long pants and the wind blows, there was a depression was made. So we did this ALT flap, small ALT for the aesthetic cosmetic reason. So I think I showed this picture several times. This patient had this trauma. The car went over her foot. So this defect, there are many ways to treat it. We can just do the amputation of the toes and do the skin graft. That's one way we can do. But problem was that this patient was a dancer. So you have to preserve the proximal phalanx as much as possible. So we did minimal amputation and did the flap coverage. This is donor side. After 5 years, the scar become quite good. And yeah, this was after 1 year. This is entrance exam. And can you tell which foot she had a amputation? Also for the large defects, like the 23 by 11.5 centimeter defect, we elevate skip flap. The donor side was closed primarily. Yeah, skip. I think it doesn't have any limitations now. So we published many papers about it, and this is the latest anatomical paper we presented with Jingan. And as you can see, this is a superficial branch, and this is an axial pattern. So my toolbox now, most of the flaps, I do skip flap. And the wound healing is one of the best tool I have. So this was the algorithm we choose the flap, but now the skip is the common way we do coverage. But what if the limb salvage is not possible? We have to do the BK amputation. And actually this is a bilateral AK patient, and it's really difficult for them to ambulate. So we wanted to have the robotic processes with the intuitive control. Intuitive control means the robot moves based on the patient will. So we co-work with other institutes, and we try to make the interface. The interface is a lesion that collects the muscular or the nerve signal, and that's transmit that signal to the robot. So we put this kind of a sensor and put on the muscle near the nerve, and you can see this is a signal from the rabbit, and it's transferred to the machine, and it's amplified the signal, and we're moving this robotic foot. So as you can see, the limb movement, it's quite natural, right? So it's not like the usual processes we have. So also you can have with the Bluetooth connection, and as you can see, the ankle movement is slightly better than the processes without the intuitive control. Yeah, maybe my toolbox, robotic processes will be one part. So build your own reconstructive toolbox. Yeah, okay. Any questions?